Some of the other non-motor symptoms that people may get include low blood pressure, skin changes, so redness and flaking, which is usually seborrheic dermatitis, swallowing difficulties some people get, again, not everybody, changes in speech, the voice often gets softer, nausea sometimes happens with or without medications, sexual dysfunction can happen, urinary symptoms, usually frequency and difficulty getting to the bathroom on time, temperature regulation dysfunction where, I feel hot when everyone else in the room is cold and I'm breaking out in the sweats during the night and that kind of thing. Cognitive changes, so changes in thinking and memory, not necessarily dementia, but some early changes in things like multitasking and so forth. And pain. We think of it as a motor disorder, but some people get pain in the joints or muscles, especially when the medication wears off. So those are just some of the non-motor symptoms of Parkinson's. Now there are some that we look at in particular because they often happen before people get the motor symptoms of the disease, and these are depression, which is mostly more like an anxiety, sleep disorders, and we'll talk about that more in a minute, constipation, which is almost universal in Parkinson's, and anosmia, so loss of sense of smell. And these things can happen 10 or more years before the first motor symptom. So there's a lot of interest now in finding people that have these things before they have even a tremor and saying, gee, could we try some kind of innovation or new medication then to keep this from converting to motor Parkinson's? And now there's a lot of discussion about that right now. So the treatment of motor symptoms is not just medication. Anybody who's been in my clinic knows that one of the big things that I advocate is exercise. More and more things are treated with exercise. We're doing research studies to show that all kinds of things like sleep and mood and memory and as well as motor function and balance are helped by various types of exercise. So everybody has to exercise. I've had one person over the years and 20 years who was allowed to not exercise for a few weeks, and that's because she had a cardiac condition that was unstable, so her cardiologist didn't want her to exercise. But as soon as they got her on the right medicine, she had to exercise like everybody else. And believe me, I've heard every excuse in the book for not exercising, and they're just a bunch of baloney. If anybody thinks they have a good excuse, I'm welcome to hear it, because there just aren't any. One lady said once, oh, my mother can't exercise. She uses a walker. I said, well, that's all the more reason why she should be exercising. So physical therapy is good, especially if you have an experienced physical therapist like the one we just hired. Occupational therapy for things like hand function and making some tasks easier. Surgery for a select small group of patients. Stress management is very, very big because almost every patient I've ever met tells me that stress aggravates their symptoms. Almost everybody. Now, everybody's surprised to hear that I've heard that before because I think they're the only one that has noticed that if they're in a stressful situation, they're shaking more. But no, everybody says the same thing. Stress management is very important. And one thing I forgot to put on here is that your motor symptoms will be better if your sleep is better. So treating sleep issues is very, very important because when you have Parkinson's, you typically will have good days and bad days. And one of the most important things that predicts a bad day is poor sleep the night before. So I spend a lot of time talking to my patients about sleep. All right, so we talked about exercise. Everybody has to do it. Now, the medical therapy. So we have a certain number of medications for the motor symptoms of Parkinson's. And I'll talk a little bit about some of the medications we use for other non-motor symptoms of Parkinson's as well. So selegiline and rasagiline are what are called Mao inhibitors. And what that means is that they are from a class of drugs that inhibit the breakdown of dopamine. So they enable your own dopamine to build up a little bit in the brain. There's also always been some question over the years as to whether selegiline and rasagiline slow down the progression of Parkinson's. And there's some data that at least rasagiline might do that to some extent. You have to be careful with selegiline. It's the old-fashioned one, and it is not prescribed as monotherapy for new Parkinson's, even though sometimes we use it that way. but it is also broken down into sort of an amphetamine-like product. So this can be okay if somebody's a little bit low energy during the day, but it also can interfere with sleep. So rasagiline is the one whose brand name Azilect. There's some data that it may slow the progression a little bit, although the FDA has not let them put that on the labeling as of this point. It is approved both as therapy for early Parkinson's and an add-on to levodopa. And as I mentioned, it can cause, if there's some suggestion that it may slow the progression a little bit, although this is still controversial. In one of the studies, when it was added on to levodopa, it gave an extra about 1.4 hours of on time a day in patients that were having motor fluctuations, generally very well tolerated. And there used to be some goofy diet you were supposed to be on where you couldn't have sausage or cheese or whatever. That's all gone now. They've shown that none of that stuff's important, so you can eat whatever you want. Did anyone ever see that list of things you weren't supposed to eat on Azilect? And the only thing, does anyone know the only thing on there you still shouldn't eat? What?
Rotten meat.
Rotten meat, yes. They had on there, don't eat spoiled meat. And I still advise not doing that. But you can have all the good cheese and so forth that you want. But so at least I've got one patient who's paying attention. That's good. No rotten meat. Now, anticholinergics are this class of drugs that I personally don't like and I hardly ever use. These are drugs like trihexyphenidyl and benztropine that are good for tremor but cause a lot of side effects, and I don't like to use them. Occasionally I'll use some in a very, very early patient who's young and otherwise healthy. But as people get older, they can tolerate less and less of this class of drug. Dry mouth, constipation, psychosis, memory loss, urinary retention, blurred vision, etc. So I generally avoid this particular class of drugs. You won't see me using too much of it because I've had bad experiences with it in the past. Again, occasionally it's useful in young patients with tremor, but I generally don't use it in anybody who's older. And what is old, you might say? It's a relative term in my clinic because I've got some people who are 50 who look like they're 110, and I've got a 91-year-old guy who doesn't look a day over 60, doesn't even have a hearing aid, and looks like $1 million. So it's more like the kind of age characteristics you inherited from good genes and good living than your specific chronological age. Now, Amantadine has some things in common with the anticholinergics, but usually it's pretty well tolerated, especially in people who are on the younger side in my clinic. It can help with tremor and sometimes rigidity and other symptoms. You have to be really careful with it if your kidneys are not too perky, so I usually will check a kidney test, a blood test for kidney function. And it's cleared by the kidney, so if something changes with your kidney function, you can suddenly have side effects with it even if you didn't before. Some people get this weird rash on their ankles with this drug. Unfortunately, it seems like the people where it works best get this funky rash and then I have to take them off of it. It's sort of a splotchy red rash. It's not a raised itchy rash, it's just sort of it's called livido reticularis. So like an angry net of a rash. So Amantadine, sometimes it works and sometimes it doesn't. Some of these older drugs, we don't know why they work in the first place, so we don't know who's gonna have a benefit from them or who aren't. Does anyone know what Amantadine started out as? A flu drug, yeah. So what happened is before we had good treatments for Parkinson's, they gave this drug out to people with the flu, and the ones who had Parkinson's, some of them said, oh gee, my Parkinson's is better. So they said, oh, it must be a Parkinson's drug, even though we don't know exactly how it works. So we still use it as one, we don't know everything about how it works. And when people get dyskinesias, motor fluctuations and involuntary movements, sometimes it'll help smooth that out a little bit too. So we generally use it in early Parkinson's, and then if people start getting dyskinesias, does everybody know what dyskinesias are? Involuntary movements like Michael J. Fox has, only he has probably the most extreme version because he takes extra medicine when he's going to speak in public. So those movements are a side effect of the medications that he takes for his Parkinson's and not part of the Parkinson's itself. So levodopa, most people eventually will need levodopa. But levodopa has first of all, it's got some bad press. it needs a new PR department because there's a lot of stuff on the internet about how this drug only works for 5 years or only works for 8 years or, hastens the progression of the Parkinson's. I mean, you name it, there are all kinds of bizarre rumors out there. None of that is true. What is true is that some people that are taking levodopa therapy will eventually develop some dyskinesias. We don't know exactly how many, and there's some people that never do, but some people will develop a little bit of rocking. The problem I have is that people who don't take levodopa and refuse to take it because they're afraid of that side effect, they don't look normal anyway, right? Because they're slow and they're stiff and they're walking like an old person and having a tremor. So I would rather see somebody able to move freely and then maybe have a little bit of rocking at the peak of their dose than see somebody who's dragging half of their body around. So I have these discussions all the time because this is California. So about at least 2/3 of my patients come to my clinic and say, like they're the first person who's ever thought of it, I prefer to treat this holistically without medications. So some of you are probably thinking, oh, I remember saying that when I first came to see her. And it's a great idea. We would all be really happy if that worked. But the problem is that dopamine is something that your brain needs to function. So sooner or later, you're going to have to put some of it back in there. It would be like if you were a severe diabetic and you said, I prefer not to use insulin because I want to get my body healthy without using any drugs. Well, it's a nice idea, and to some extent you could maybe do that with very good diet control, but sooner or later, if you need insulin, you have to take insulin, otherwise it's not compatible with life. And levodopa is the same kind of thing. Or thyroid medicine. There are all these people on thyroid medicine saying, I prefer to treat my Parkinson's holistically. And I'm like, well, you'd probably die without your thyroid replacement, and sooner or later the same thing would probably happen. In fact, it would happen. There are these studies that show that the longevity of Parkinson's patients has increased dramatically since the availability of levodopa. So it makes you live longer, it makes you able to continue functioning, continue to exercise, and so forth. So it's a good drug. Put it off for a while with these other drugs, but sooner or later people are going to need levodopa. Now, the worst thing is when somebody doesn't respond to levodopa. So some kinds of Parkinson's have a really good response to levodopa, and some have a so-so response, and some don't have any response. And it's really, it's a bad thing when you don't have a response to levodopa, because it's not like we have 10 other drugs waiting in the wings that can take the place of that drug. Okay, so the long-term complications of levodopa therapy include this wearing off of effect, usually after a few hours, that some people never get and some people get after 6 months, really variable. And true on-off, which means you turn off in the middle of your dose, which is fortunately really quite rare. The dyskinesias, as I mentioned. And then some people who do go on to have more significant cognitive changes or memory changes will develop some kinds of hallucinations with the levodopa. Now, some people think that their spouse is already hallucinating because they wake up in the middle of the night having weird dreams and they're kind of confused. That's a little bit different. When it's associated with sleep, we're not quite as concerned about it as a side effect. It's not that we're not concerned about it, but we don't consider it so much of a levodopa side effect as when it happens in broad daylight when you're wide awake and you start having a conversation with your Aunt Helen who's been dead for 20 years. That makes us sit up and take notice, especially when people lose insight. Losing insight means having insight means you see Aunt Helen at the lunch table and you say, it's really weird, it looks like Aunt Helen, but she's been dead for 20 years. That means you've still retained some ability to sort out what's real and what isn't. But the problem with Parkinson's hallucinations, and again, not everybody gets them, fortunately, but is that when you get them, and you get to the point where you lose insight, the brain makes an incredibly realistic image. And people have a really hard time looking at what looks for all the world like Aunt Helen, but she's not there. And they just really have a hard time believing that Aunt Helen isn't in the room. And this gets where it gets to be a real problem, because then, at that point, usually people start to become sort of paranoid, or saying there are people in the house having parties all night, they're frightening me, and then they start calling the police, or they start trying to hit them with a 2x4 or something can be very dangerous. So when you start having a little kitty cat go by out of the corner of your eye, you need to let us know so that we can say, we're going to have to watch because we don't want this to escalate and turn into something more significant, because it can be really problematic. Some people don't want to tell you about it because they think you're going to think they're nuts and have them hauled off to the loony bin. So I try to emphasize, this doesn't mean you're going crazy. It means that you're having a side effect of the medication that we need to keep under control. Any questions about that?
How do you keep it under control?
Well, we usually use drugs like some of the memory drugs that I'll talk about later, and then there are drugs like quetiapine or Seroquel to try to keep it under control. And then we've got some new drugs that we're studying in the clinic to try to keep it under control. We can't always do it, but we've gotten a lot better than we used to be able to.
And you take those drugs along with the Levodopa?
Yeah, sometimes those drugs enable. In the old days when I was in my training, we sometimes used to have to take them off all their medicines so they'd stop hallucinating. And then, of course, they would freeze up and not be able to move or swallow or walk. It was terrible. So now, usually with the drugs that we have, we can come to a balance where you can take enough levodopa to keep moving and swallowing and so forth, but not have so many of the hallucinations. But it is challenging. Okay. So some of the things we think are associated with the dyskinesias are giving great big peak doses and then going down to nothing between the doses. So what I generally try to do with my patients is give more smaller, more frequent doses over the course of the day, which is annoying and a pain in the neck, but it seems like if you're closer to what the brain would do if it were healthy, the brain seems to like that better. And in early Parkinson's, usually you can take the medicine 3 times a day and you don't have any side effects, and you think the doctor's a genius and everything's happy, and then later on, of course, you know that's not going to last. What you're trying to do is get in this, what we call the threshold up there, that little brown lump, which is where things are working well and you're not having side effects. And in early Parkinson's, it's relatively easy to do that. And we think the reason for that is that in early Parkinson's, you're still making a pretty good amount of dopamine in your brain. And it's only later on, as some of your cells have gone away, that we start seeing the fluctuations, probably because you don't have that buffer cushion of dopamine neurons in your brain. Does that make sense? So it's not that the levodopa is suddenly causing this problem, it's that your brain doesn't have the buffer system of cells making dopamine that it used to, so you're more dependent on what you're taking orally. So you start to see the effects rise and fall with your blood levels. And this blood level the levodopa does not stay around for a long time in the blood. We actually are working on a new medicine, a new form of levodopa that's probably going to stay around longer. I hope they'll be on the market within the next year. That's very exciting. So in late Parkinson's, again, you don't have that cushion, so it gets harder to hit that area, and some people at the peak of the dose get involuntary movements. So you're constantly trying to get just enough in there to keep things working, but not so much that you get involuntary movements. And then to complicate it more, most people get the involuntary movements at the peak of the dose. Some people don't get it till the medicine starts to wear off, just to make things more confusing.